breast cancer survivor. Oh my God, this is the first time I say it.
Good morning. We're gathered here today to discuss the management of the HER2 positive breast cancer. Gathered in the table with us are three other experts in the area. I'm Dr. Silva, a surgical oncologist at the Fred and Pamela Buffett Cancer Center at the Nebraska Medical Center in Nebraska, and I will have my colleagues introduce themselves.
I'm Lisa Carey. I'm the Chief of Hematology Oncology at the University of North Carolina Lineberger Comprehensive Cancer Center.
I'm Wadad Hanna. I'm a breast pathologist at Sunnybrook Health Science Center, Professor of Pathology at University of Toronto, Canada.
I'm Julia White. I'm the Director of Breast Radiation Oncology at the Stephanie Spielman Comprehensive Breast Center at the Ohio State University Comprehensive Cancer Center.
As our last case, we're going to address a situation of a patient with a HER2 positive breast cancer who may be inoperable at the outset. This is a post-menopausal individual with a T2, N3, ER/PR negative and HER2 positive breast cancer, but unfortunately, as we mentioned earlier, she has palpable supraclavicular lymph nodes and radiographic evidence of mammary nodal metastases. So to that end, she would not be considered a candidate for surgery, and thus, in a multidisciplinary conference, she would be primarily the subject of discussion with our colleagues in both radiation oncology and medical oncology. And of course, in most centers, if the patient comes with their biopsies from an outside facility, they would be reviewed by our pathologist, Dr. Hanna, as I suspect they do in your hospital in the same way.
Yes, we always do that.
Dr. White, do you call for a biopsy of the supraclavicular nodes prior to enacting any treatment plan?
I think it's very helpful to have confirmation of, if there's any question about the supraclavicular nodes, to have a pathologic confirmation. From a radiation oncologist point of view, these are areas where we're going to dose escalate them beyond our standard adjuvant radiation doses, and then we really worry about morbidity. So if we're going to commit them to that morbidity of dose escalation, I think we all sleep better at night, and it's fair to the patient to have pathologic confirmation of them.
Yes.
To carry a metastatic workup, in this case, clearly would be part of your treatment.
Yeah, so I think, the guidelines in my own clinical practice are very concordant in this respect, which is a clinical stage 3 is when, even if they're asymptomatic, it warrants systemic staging and looking for asymptomatic distant disease. Right. Which then needs to be confirmed also pathologically, because it has huge implications for how we're going to approach the patient.
So in other words, if the patient were to have bone mets, you would still then ask for biopsy confirmation of the same?
Yes.
Sure. Good. And in this setting, absent any evidence of metastatic disease elsewhere, what would your plan be?
Well, this is an incredibly high-risk circumstance, but is still, what we're going to approach is curative intent therapy. And so this is a setting in which I think, we would use everything that we have available to us, which would be a third-generation chemotherapy regimen plus trastuzumab. And this is where I think, pertuzumab, which has been FDA approved for the locally advanced situation and the neoadjuvant setting. And to be honest, the NCCN guidelines have said if it's approved in the neoadjuvant setting and appropriate, it ought to be the same for adjuvant. This is the kind of patient that is a poster child for incorporating a second HER2 targeted agent. None of us knows if that approach is going to translate into improved survival, so it's not routine for all patients with HER2 positive disease. Pretty soon we'll have the affinity trial and we'll know whether, in general this changes event-free and overall survival. But certainly for this patient, particularly if they're young and otherwise healthy, I would be very aggressive and use all the drugs that I have available.
Following the completion of your neoadjuvant therapy, you would restage this patient?
We don't routinely. You mean for distant disease?
Right.
Yeah.
Prior to having Dr. White see the patient,
right.
Make sure they haven't progressed in the interval.
Well, we typically would stage the, obviously the local area, because that helps both the surgeon and the radiation oncologist. If the patient has had a very good response in the, local disease, we don't typically require it. I think you have to take that on a case-by-case basis.
But even if she had a complete pathologic response that was presaged by a good clinical response, Dr. White, that would not affect your radiation ports that you have already
It
elected
really
at the
doesn't.
outset.
And I think this is an important point. We see many patients who in neoadjuvant chemotherapy setting who are really the clinical stage 2 at the outside, prior to the era of neoadjuvant chemotherapy would go to surgery first. Those are the patients for whom we think response to chemotherapy might help them be able to have less local regional therapy. And we're trying to study that on both the Alliance and the Energy trials. But for this patient, she is so locally advanced, as already stated, that she has an opportunity for curative therapy, and excellent response to I would say primary chemotherapy, or neoadjuvant chemotherapy in this case, really is good news for her prognosis, but it doesn't change our intent of radiotherapy. And so we're going to watch what the response is, and we wouldn't restage her distantly, but we want to make sure how much the local regional disease has responded, how much surgery you will do, and then we're going to tailor our radiotherapy doses to the response. So someone who responds completely on repeat regional staging prior to surgery, we are going to continue to dose escalate to the internal mammary nodes and to the supraclavicular nodes that were there, because we're presuming you're not taking them out. We think they need a specific local therapy, and it's going to be radiotherapy alone in those cases. But if there's some sense that there are still nodes there after appropriate drugs, after appropriate neoadjuvant therapy, and you're not going to take them out, then we're going to make the tough decision to go even higher in dose for response if we think there's gross disease there. Because radiotherapy for gross disease is generally a higher dose than we would do for microscopic disease. So it really does affect how we approach radiotherapy in terms of dose will change, but what we'll actually target, even in a path response, doesn't change. We're happy that she has a path response for her prognosis.
Yeah, I think because she's locally so advanced that it would be hard to argue that you would not give her every option at stage at presentation.
Right.
But Dr. Carey, would you encourage this person to have a mastectomy? Should she have a complete clinical response?
No, not necessarily. I mean, I think, if the patient she had a T2 tumor to begin with, I think, we always think of the management of the breast and the nodal basins as being, sort of independent. I mean, I think she could have, if she had, good downstaging was otherwise appropriate, she could certainly have breast conservation. She is definitely going to be radiated no matter what.
Right.
And that's how we discuss with these patients. They're breast on, breast off for us. We think there's not much that's going to change. It's her nodes are driving her disease.
Yes, and her prognosis.
I mean, this is a case that I would do the MRI after the chemo, just to make sure that in the event that we were going to do something short of mastectomy, that I would not have to go back to the OR with a positive margin. It would be discouraging in this setting. Most of our surgeons would do a mastectomy in this setting. Although in my practice, we've had, as Dr. Carey pointed out, patients with very large tumors who, despite the presence of residual microcalcs on a mammogram after a very generous sampling of the primary tumor site, have had a complete pathologic response, and that seems to be a salutary effect. So in this setting, I think the patient would be discussed at our conference. And as Dr. White pointed out, if she has a very good response to the preoperative chemotherapy, she would either have lumpectomy or mastectomy with a complete, almost therapeutic, if you believe there's such a thing, therapeutic axillary node dissection, although clearly that would ignore the supraclaves. I don't think anybody would chase those right now.
And I believe she had internal memory. So that's
exactly.
So those are the things that really, as we said, are the drivers of her prognosis. And so I think that I would anticipate her local regional control, as long as she has an appropriate, surgery, be it lumpectomy with negative margins or mastectomy, I would think she would have equivalent outcome, quite honestly.
Mm-hmm.
Now, is it reasonable to assume, as many have, that a complete pathologic response in a, say, T2, T3 lesion, node positive lesion, has a similar recurrence rate than if it was a T1 N1 lesion? If both have a PCR.
Yeah. So what we know about PCR is that it has, compared to non-PCR, a better prognosis. But it also is true that PCR does not mean that the cancer cannot recur. And those that have a PCR at surgery but do recur, among the predictors of that are things like inflammatory disease, stage 3 disease up front, et cetera. So in this case, even with a PCR, I would consider it a relatively high risk, although I'd certainly be encouraged if she had a PCR.
And
but I wouldn't change anything.
In the post-operative, no, I agree with that.
I wouldn't change anything.
In the post-operative setting, would you do anything other than a clinical exam and a mammogram?
Well, you mean outside of completing her adjuvant therapy
Yes,
as previously? No, no, not unless there was something. I mean, if there was something up front that you were concerned about that you wanted to follow. I mean, I think sometimes there are things that are clinically indicated for a follow-up, but in the absence of that, I follow ASCO surveillance guidelines pretty consistently, stages 1, 2, and 3.
Right. And Dr. Hanna, in the final pathology report, can you be absolutely sure that there is in fact a PCR?
This is a good question because obviously we don't sample 100% of the tissue, and that's why, particularly in the T3 tumor, when there might be pockets that you haven't sampled, but we X-ray the slices and we go after calcification. Particularly in HER2 positive disease, the DCIS is associated with calcification and central necrosis, so that's a good guide. And we are more aggressive in sampling in post-neoadjuvant to ensure that this is complete pathological response. We also, which is not necessarily important, but we do keratin stains to ensure also that sometimes the cells look funny, is to make sure that these cells wandering around are not cancer cells, and to help us identify if there's any residual disease. We also examine the lymph nodes if they're going to come out very extensively, because if you see fibrosis and histiocytes and so on, you want to make sure that there is no cancer cells lying there. But 100%, I think only God knows.
And there's been some debate, Dr. White, about the presence of residual microcalcs in a setting like this, that the tumor may go away completely and the surgeon does a generous lumpectomy, and there's still some little areas of microcalc separately, and the question is whether that is an indication for a mastectomy despite an attempt at breast conservation, or whether the calcs in and of themselves, in the presence of a PCR, would admonish you to either do more or have the surgeon go back and finish the mastectomy.
I think this is a really great debate. I mean, I think, as you know, first of all, we need to establish up front that the calcs are related to malignancy, and that's very helpful from our pathologist. The second thing is, it's hard to know is calcs any more meaningful than seeing post-neoadjuvant fibrosis or other evidence. And I don't think we know that. Calcs is in and of itself not a malignant potential, right? So far for me, as long as my pathologist, to the best of our ability, and our surgeons to the best of their ability, think that we up front knew where the tumor was on our staging, and that we see a type of response if we're redoing a lumpectomy where she's not on her MRI, she's had kind of a unifocal response. You can have where it kind of breaks up into little tumors, and I think that's a multifocal response, and that's more concerning on MRI. So she's had a good response, and we think to the best of our ability. I wouldn't be driven to change my clinical decision making based on calcs if pathologically and clinically and imaging-wise everything adds up.
Yeah, I think there was a recent publication just suggesting that not all of those calcifications, as you know, may be associated with any residual tumor, although some were. And yet, I think most of us have not made an effort to get all of the calcifications out if we can. We make a good effort to get just about all, but in some of those cases, then you might as well do a mastectomy, in which case you're defeating the purpose of the preoperative setting. But I think we've had one case where the patient went back, and unfortunately there was nothing there, and you just have to live with your decision making. But other than that, I think this is a good case because it does suggest that the initial staging of the patient is that much more important than perhaps any of the other patients that we had, because that clearly does affect your decision making, certainly in the radiation oncology planning. One more reason for which all these patients should be seen by the multidisciplinary conference. We have a patient just like this now with supraclav nodes, and our radiologist asked that we do a PET. I'm not sure he noticed them on the CT, on the planning CT, and he asked for a PET, the argument being that if the PET was positive, he would then be inclined to do the more extensive field, but if the PET was negative, he would not What do you think
No,
about
I don't. That one doesn't quite make sense to me in this case. So this is a patient who has both internal mammary nodes and supraclavicular
Right,
nodal.
right.
She's extraordinarily high risk,
Right.
yet not has declared herself metastatically.
Surely.
We can clinically document. So in that case, whether she has had a complete response or not, my fields, what I'm going to target, is not going to change. I'm still going to target the supraclavicular internal mammary and the what's retained in the axilla. I think if I had a and I do repeat the CT scan of the thorax. Now, if the diagnostic radiologist said, I'm unsure, I think it would help my interpretation to get a PET of those areas. I would go along with that. But if there was gross disease left on a CT scan, it would affect I would dose escalate.
Sure.
But it wouldn't change my decision to target those areas. I want to clarify.
Yeah, even if the PET were to normalize, you still would do the same thing.
Not in this patient. This is it's a supraclavicular positive patient is an N3 disease.
Right.
And even in the setting of complete pathologic response, we need to be you would need still to be aggressive, and she needs radiotherapy to those. She needs a specific local therapy, and if you're not going to dissect the supraclavicular, which is done rarely, she needs a specific local therapy to her nodes, and it's radiotherapy in this case to both her supraclavicular and internal mammary nodes.
Yeah, I think the point you're making is that in a patient with a good response, as Dr. Carey said, it would be wrong not to go all out in this particular setting with the radiation fields to get the most that we can of this otherwise favorable chemotherapy response.
Right.
I think maybe that was one of the points made by the editorial that preceded yours in the JCO regarding the use of neoadjuvant impact on radiation therapy.
It is, but I also think it relates back to this question of what do you start with? We think response is an important prognosticator. In some cases, we're hoping to determine we can predict what type of treatments we do. But for someone who's this locally advanced, she's still high risk, even with a good, I mean, going back to Dr. Carey's statement, she's still high risk. It's better for her prognosis to be a responder, right?
I mean, there is a distinction, right? I mean, if the earlier conversation about whether it's still okay to do breast conservation, you know, that's two local therapies kind of working together, and so it's fine to have either mastectomy or breast conservation in a patient regardless of, you know, treat what's left. But the nodal basins, the rest of the nodal basins, you're not going to operate on them.
The surgical
So
field.
they need a
better
specific
some-
local
Right,
therapy.
they're outside the
That's
surgical
how you
field.
think
We
about
really
it.
have to,
Gotta
the
have
philosophy
something.
is
That is correct. No,
And
I
this is
think
different
all
than
agree.
those two first
Right.
cases we saw, which
Right.
were not this advanced.
right.
Well, thank you, panelists, and that concludes our third session. Thank you.